Besides of this, there are also 2 clinical trials on whole system of anthroposophic cancer treatment that compares anthroposophic medicine with other medical systems. If we have enough time, I will show them to you shortly later. Now I'm first going to the prospective control trials. As I told you, we did a criteria-based quality assessment, and these are the criteria for quality assessment of randomized and non-randomized trials. The first part of it are on different kind of biases, and the other part is on other important methodologic aspects of clinical trials like GCP guidelines, etc. The methodological quality, here you can see the result of our quality assessment of the randomized controlled trials. Plus means that the point was fulfilled, minus means that it was not fulfilled, and the brackets means it was in between. And the methodological quality differed substantially. Especially in older studies, the quality of design, conduction, and reporting was far below the standard that is today regarded as optimal or necessary. During the last years, the study quality has markedly increased, and some recent trials were reasonably well conducted. Here's the same for the non-randomized trial. I don't think we have to go into details here now. This is a list of the characteristics of the randomized trials, like cancer site, intervention, all the treatment arms, treatment groups, outcome on survival, on tumor behavior, and other outcomes. I will summarize them for you, but I will summarize randomized and non-randomized trials together. 14 randomized trials included 2,500 participants. Non-randomized trials included a little bit more patients. Cancer sites studied in randomized and non-randomized trials were 9 times breast cancer, 8 times lung cancer, 5 times colon cancer, stomach cancer, 3 times, 2 times each melanoma, ovarian, and other genital carcinomas, and 1 head and neck cancer. The stages ranged from early detected to advanced disease. 17 trials compared 2 arms. 4 trials had 3 arms, and 1 trial consisted of 2 overlapping parts with 3 and 4 arms. The length of follow-up was varied from months to years. All treatment groups received conventional care when indicated. In 7 trials, mistletoe was administered concurrent with chemotherapy, radiotherapy, or surgery. And 5 of these trials assessed reduction of side effects from cytoreductive therapies, including surgery. These are the study characteristics for the non-randomized trials. Now I will shortly summarize the overall results, and then I will go into more details. 17 of the RCTs and N-RCTs investigated survival. 8 reported statistically significant positive effect, 8 a trend, 1 a 0 effect. And also here the quality varied. Disease-free survival was investigated in 2 trials. 1 had a 0 effect, 1 a negative trend. This outcome parameter is can be easily affected by bias. It's bias sensitive, and they are not completely free of bias. Remission was investigated in 3 trials. 1 had a statistically significant positive effect, 1 showed a trend, and 1 a 0 effect. These 3 trials also don't belong to the methodologically strongest trials, so I think the cohort studies say more about this point than these 3 trials. They have some difficulties. Better are the trials that cover the last 2 outcome parameters. 5 investigated quality of life. Qual means quality of life. 4 reported a statistically significant positive effect, and 1 trial didn't report any results, so we don't know. 5 trials also investigated quality of life and reduction of toxicity of surgery, chemotherapy, and radiation. 3 of them had a statistically significant positive effect. 1 very small pilot trial with just 18 patients had a mixed result, no effect on quality of life, but one has to say the quality of life was not improved anyway, it was good. It was on early breast cancer patients. It has had a significant effect on reduction of activated NK cells. So we put it on plus and 0. And 1 study mentioned positive effects, but didn't bring any, didn't do a computation of significance. Therefore, we put it as a positive trend. 1 of these trials also reported that with additional mistletoe therapy, the dosage of cisplatin and holoxan could be increased because of less side effects. Most of these trials were conducted in conventional institutions, in academic or larger community hospitals or cancer centers. When you read all these mistletoe trials and when you deal a lot with the researchers that do them, then you get to hear a lot about problems that occur and that are just important to know when you plan a trial or when you judge them. First point is that randomization is often not possible, or enrollment of the patient often fails. And I want to give you an example from the University of Heidelberg that just recently published about this. They wanted to do a randomized controlled trial on breast cancer. And they first wanted to do a feasibility study, whether it would be possible at all. And they did it for 2.5 years, and during this time, 1,922 women were operated on breast tumors. 500 had benign tumor, and 880 had to be excluded because of exclusion criteria or no inclusion criteria. So about 500, about 1/4 of the initial patients met the inclusion criteria. Of these patients, most of them had to be excluded because of other reasons. Many principally rejected the participation in a trial. Some already had mistletoe therapy, and several had other reasons. So in the end, just 29 patients agreed to participate in the randomized controlled trial. This is 1.5% of the initial operated patients, and it's 2% of the women with breast cancer, confirmed breast cancer. So the university decided that a randomized control would not be possible because 29 patients in 2.5 years is just too few. So other problems is blinding. Blinding is only possible pro forma. I mean, you can give a placebo instead, but mistletoe injection makes strong local reaction. It gives reddening and swelling, and 2 double-blind trials now confirmed that blinded mistletoe application is unblinded by nearly all patients and physicians. Protocol deviations are frequent, and I don't want to go into all details here now. Mistletoe application, another problem is that mistletoe application is primarily in institutions with no infrastructure and special expertise for clinical research, and vice versa. And this makes some problems too. The enrollment of appropriate number of patients within reasonable time is difficult too. I just mentioned this example. I know a lot of randomized controlled trials that were stopped while running because they just couldn't get enough patients. Because the main reason is the preference, either for or against. Now I want to show you a few of the more recent and qualitatively better and significant randomized trials so you get a better impression of the strengths and weaknesses.